So a lot of people, when they think about when they wake up in the morning to a Today programme thing saying, well, we found the genes for schizophrenia, which does happen with quite nauseous regularity, then that's what they think. What they think is that a major gene has been found, and that's going to lead to a genetic test, and on the plus side, and possibly a therapeutic intervention because the pathways will be discovered and all the rest of it. And it doesn't mean that, of course. At least it doesn't mean like that anytime soon. One of the fascinating things about the polygenic risk score idea, which I would love to be able to communicate to the general public, is that it shows that, well, Kenneth Kendler's got a paper coming out in a few months of this pre-publication thing, which is a review. It's just a history of this whole thing. And he says the risk of schizophrenia is widely distributed in the population. The genetic risk is so widely distributed in the population, all of us carry some risk to some degree.
That's undoubtedly true.
Yeah.
We've all got genes for schizophrenia,
and
exactly. Bipolar disorder and autism.
Exactly. Yeah. And I, when I'm talking to students about this, I usually make that point out. Everybody in this room will have some of these genes. The continuum model, which is actually supported by the polygenic risk idea, actually, but the continuum model does divide, cuts down the us and them distinction between people with psychiatric problems and people who are not, and I think that's very important. I think it's
yeah. I mean, it can do, but at risk of trivializing issue. I suppose that is the risk of the kind of continuum approach to mental distress is at its most fundamental level. I think that if we can all have these problems, then I think that it might lead some people at least to think, oh well, I've had that problem, but I just pulled out my socks and got on with it, or shouldn't that person in that situation just try a bit harder or deal with stress a bit better. So I think that's the risk of a kind of continuum approach, is that it can feed into those unhelpful attitudes that people can have. So I think mental health professionals, we stigmatise mental illness ourselves, I think, and we have to struggle with that ourselves. And I don't think that, yes, classification or diagnostic labels could cut either way, I think, depending on how they're used and the connotations that they're associated with. And
one of the things we should try and tell students never to do is to call people schizophrenic.
Yeah.
Because that implies that it's something intrinsic. So you talk about, I know it sounds a bit PC and around the but if you talk about people being diagnosed with schizophrenia or having schizophrenia symptoms or something like that, it to some extent at least disentangles, or at least tries to disentangle, the idea that the person, whatever you think about the schizophrenia label, or even a hardline, narrowly reductionist biological point of view, would admit that there's more to the person than the label schizophrenia. And so how we talk, I think, is very important.
So classification systems are ...
Okay, well, a work in progress which is yet to be bettered is what I would say.
Well, I could actually just more or less say a work in progress which could be made much better might be my kind of response.